Welcome back, guys. Today we are going to discuss this very important vitamin, very important fat soluble vitamin to be precise, is vitamin D. Vitamin D. Let's start this discussion. First, vitamin D is also known as this sunshine vitamin. We know sunlight is the most important source of vitamin D, so this is also known as sunshine vitamin. Vitamin D has a group of sterols having a hormone-like functions. It's a group of sterols having hormone-like functions. Vitamin D. We're going to see some form. First is ergocalciferol. Ergocalciferol, which is the vitamin D2. It's from fungus ergot. ERGOT. It's from fungus ergot. Ergocalciferol, vitamin D2 from fungus ergot. Next is cholecalciferol. It is vitamin D3. This is from animal sources. Cholecalciferol, vitamin D3 is from animal sources. Ergocalciferol, vitamin D2 from fungus ergot. So now we are going to see some process of endogenous synthesis. Endogenous synthesis of vitamin B2, vitamin D complexes, endogenous synthesis. So first we are going to see this UVB light. UVB light, that is wavelength is 292 315 nanometers. This UVB light of this nanometer range, it falls on skin. UVB light from sun rays, it falls on skin. It converts 7-dehydrocholesterol to, remember, cholecalciferol. This vitamin D3 form, cholecalciferol, vitamin D3. 7-dehydrocholesterol is converted to cholecalciferol in presence of this UVB light in the skin. Very important first step, you need to remember this. Also we get from dietary sources cholecalciferol. From dietary sources. So 7-dehydrocholesterol to cholecalciferol, and from dietary sources cholecalciferol. These two cholecalciferol sources gets in blood. From skin we are going to blood. In blood there is a DBP. It is D binding protein. Vitamin A, we have seen RBP, retinol binding protein. Here it's DBP, D binding protein, which is alpha 1 globulin. D binding protein or alpha 1 globulin. This first goes to liver. Okay, this organ, liver, this along with D binding protein, this cholecalciferol combines and goes to liver. Here starts our discussion of metabolism. Okay, how things are getting converted we are going to see. In liver there occurs first hydroxylation reaction where N liver. After hydroxylation reaction, this is converted to 25 hydroxy cholecalciferol. 25 hydroxy cholecalciferol. First hydroxylation reaction takes place in liver. Important point to remember. To form 25 hydroxy cholecalciferol. This in turn comes to the kidneys. Okay, the kidneys. 25 hydroxy cholecalciferol comes to kidneys, where there occurs 1 alpha hydroxylase reaction. Okay, 1 alpha hydroxylase reaction. 1 alpha hydroxylase reaction is then further converted to this important compound 1,25 dihydroxy cholecalciferol. Very important compound. Remember, this step is the rate limiting step, which is 1 alpha hydroxylase reaction in the kidneys is the rate limiting step for the formation of this 1,25 dihydroxy cholecalciferol. 1,25 dihydroxy cholecalciferol. This is the most active form of vitamin D. This is the most active form of vitamin D. 1,25 dihydroxy cholecalciferol. Okay, so next point we are going to see is, remember these two compounds, this parath hormone. Okay, this parath hormone and decreased phosphate. Okay, not only phosphate but this decreased phosphate along with parath hormone level increases activity of 1 alpha hydroxylation. Activity of 1 alpha hydroxylation is increased by decreased phosphate levels and parath hormones. Remember decreased phosphate levels, not only phosphate level, decreased phosphate levels. 1 alpha hydroxylation. Okay, so if our body has enough calcium, okay, if our body has enough calcium, this 1,25 dihydroxy cholecalciferol, this is the most active form, or also remember calcitriol. Okay, 1,25 hydroxy cholecalciferol or calcitriol, this undergoes a 24 hydroxylase reaction. Enzyme is 24 hydroxylase, so the reaction is 24 hydroxylase reaction to form 24,25 dihydroxy cholecalciferol. The CC is cholecalciferol, double OH is dihydroxy, 24,25 dihydroxy cholecalciferol. This is known as, remember, calcitriol. Calcitriol by 24 hydroxylase reaction, 24,25 dihydroxy cholecalciferol or calcitriol. So seen this, some conversion and metabolism of vitamin D2, very important for our understanding. Next we're going to see is functions of vitamin D, some functions of vitamin D. Okay, first is our regulation of calcium, very important function, very important first point, regulation of calcium. This regulation of calcium is happening in, remember, in three parts, in intestine, okay, in kidneys and in bones. Intestine, in kidneys and in bones. In these three places, this regulation of calcium is taking place. So we're going to see one by one. So we know this 1,25 dihydroxy cholecalciferol. It increases calcium and phosphate levels. So first important point we're going to remember, calcitriol increases calcium and phosphate levels, and parathormone, remember, increases calcium. We know this parathormone causes resorption of the bones and increases calcium level but decreases phosphate. This is most important understanding. Parathormone increases calcium but decreases phosphate. Calcitriol or vitamin D active form increases calcium and phosphate. Vitamin D increases both calcium and phosphate. Parathormone decreases phosphate. This difference we have to keep in our mind. So first we are going to see in intestine. In intestine, this 1,25 dihydroxy cholecalciferol, it increases, remember, TRPV6 calcium transport channel. Okay, it increases TRPV6 calcium transport channel. It also increases level of calcium binding hormone, which is calbindin 9K. It increases the activity of calcium transport channel TRPV6, also the level of calcium binding protein calbindin 9K. These two ultimately in the intestine lead to increased absorption of calcium in intestine. In intestine, as a result of these two protein gain functions, TRPV6 and calbindin 9K, there is increased absorption of calcium in intestine. We have seen intestine. Now we are going to see in kidneys. In kidneys, this 1,25 dihydroxy cholecalciferol, same story here. It increases this TRPV5. Okay, you know, this is a calcium transport channel. Increases the activity of TRPV5 calcium transport channel. Also increases calbindin. Remember, in the kidneys it's 28K, intestine it's 9K, it's 28K, calbindin 28K, calcium binding protein. Okay, these two functions ultimately leads to increased reabsorption of calcium, leading to increased serum levels of calcium. Also phosphorus. Remember, the phosphorus maintenance by vitamin D takes place in the kidneys along with calcium. It also increases the level of phosphorus, where from these both functions takes place from DCT, distal convoluted tubule. Okay, next we are going to see in bones. Okay, in bones we have in osteoblasts we have a rank ligand. Okay, Okay, the ligand called rank ligand in the osteoblasts. In bones, both parathormone along with dihydroxycholecalciferol 1,25, parathormone and vitamin D both in the bones. This rank ligand is a receptor of pro-osteoblast. Okay, this rank ligand is a receptor of pro-osteoblast. This leads to maturation of pro-osteoclast. This receptor of pro-osteoblast leads to maturation of pro-osteoclasts, or you can also say osteoclasts. We know this maturation of osteoclasts favors bone resorption. Okay, maturation of osteoclast, which then later from osteoclasts favors bone resorption. So vitamin D and parathormone increases serum calcium levels. How? By increasing bone resorption by maturing the osteoclast in the bone. Remember, in bones both parathormone and vitamin D acts. Vitamin D and parathormone both increases serum calcium levels. Okay, so now we are moving on. So this vitamin D is called a holy grail of cancer medicine. Okay, this holy grail of cancer medicine is this vitamin D. Today we are going to see many people are complaining they are deficient in vitamin D. Our lifestyle has become such, we are getting so little of the early morning and evening sunshine that we are not manufacturing enough vitamin D. This vitamin D is generally called the holy grail of cancer medicine. Why? We are going to see this. Remember this level of 25 hydroxy calciferol or D level. Okay, it's 25 hydroxy, not 1.25 dihydroxy, 25 hydroxy D level. Okay, and it is less than 20 milligram per deciliter. Okay, it is less than 20 milligram per deciliter is associated with increase in incidence of remember, colon cancer and breast cancer. Okay, colon cancer and breast cancer, these are often associated with 25 hydroxy D levels less than 20 milligram per deciliter. So vitamin D is protective against pre-diabetes and metabolic syndrome. And pre-diabetes, it's protective against which vitamin D. Vitamin D is protective against pre-diabetes and metabolic syndrome. Remember this important point. And less than 20 milligram per deciliter is associated with increase in incidence of colon cancer and breast cancer. So we've seen so many functions of vitamin D associated with calcium levels, but there is an irony. Okay, there is an irony. What irony we are going to see? So So vitamin D leads to mineralization of bone. Okay, vitamin D leads to mineralization of bone. In bones we have osteoblasts. Okay, osteoblasts which leads to increase in osteocalcin. Osteocalcin, form of calcium present in bones in osteoblast, it is osteocalcin. Increased osteocalcin leads to deposit of calcium in osteoid matrix and epiphyseal cartilage. Osteoid matrix and epiphyseal cartilage. This increased osteocalcin. Okay. So we have seen before, it's vitamin D in bones leads to maturation pre-osteoclast, and osteoclast lead to bone resorption, increasing serum calcium level. But here also in this irony we see vitamin D leads to mineralization of the bone in osteoblast, leading to increased osteocalcium levels, deposition of calcium in osteoid matrix and epiphyseal cartilages. In all these cartilages, some cartilages go on to further mature and become solidified bones, deposition of calcium in osteoid matrix and epiphyseal cartilage. Next we are going to see the assay. The assay of vitamin D is, first is 25 hydroxy cholecalciferol. 25 hydroxy cholecalciferol level in blood. Okay, this is generally 20 to 100 nanogram per deciliter. 20 to 100 nanogram per deciliter. Next we are going to do is serum osteocalcin levels. Serum osteocalcin levels and 25 hydroxy cholecalciferol level in the blood. These two are the assays of vitamin D. Next we are going to see very important topic, that is nutritional rickets. Okay, very important discussion. Please listen carefully. Nutritional rickets. So we have, first we have vitamin D deficiency. Okay, this deficiency leads to decrease in serum calcium and decrease in serum phosphate. Okay, decrease in serum calcium and decrease in serum phosphate due to vitamin deficiency. This leads to a condition called secondary hyperparathyroidism. Secondary hyperparathyroidism. Okay, this secondary hyperparathyroidism in turn increases 1-alpha hydroxylation reactions. 1-alpha hydroxylation reaction increases the level 1-alpha hydroxylation reactions. This leads to increased levels of 1,25 dihydroxy cholecalciferol, active form of vitamin D. Okay, this leads to increased serum calcium levels. Vitamin D acts on the bones, increased serum calcium levels. But there is a but here. Remember, serum phosphate levels remains decreased. Level of 1,25 dihydroxycholecalciferol decreases the serum calcium levels, but serum phosphate level remains decreases. This is an important required biological finding. Serum calcium level is increased, but serum phosphate levels remains decreased. This we know. This conclusion we can draw from here is serum calcium level can be normal when during vitamin D deficiency. Very important. During vitamin deficiency, serum calcium levels can be normal. Why? We have seen here the mechanism. Due to secondary hyperparathyroidism, increased 1-alpha hydroxylation reaction leading to increased calcitriol. Calcitriol leads to increased calcium levels, but serum phosphate levels remains decreased. Important biological finding. We need to test more. That is why it's called nutritional rickets. Even after having, it's not exactly we are having sufficient of vitamin D, we are still having vitamin D deficiency, but serum calcium level is high. The important biological finding here is serum phosphate level remains low. You've seen before, calcitriol, vitamin D increases both phosphate and calcium levels. So this is the concept of nutritional rickets. Okay, so from this we are going to see some types of rickets, the deficiency manifestations, associated with rickets. Vitamin D, most important deficiency manifestation are the rickets. So types of rickets we are going to see. First is classical vitamin D deficiency rickets. Okay, classical vitamin D deficiency rickets. Second is hypophosphatemic rickets. Okay, next is we have a vitamin D resistant rickets. Okay, vitamin D resistant rickets. This is called Fanconi's syndrome. We are going to learn this Fanconi syndrome in renal physiology. Fanconi syndrome. How the syndrome occurs. This is a form of vitamin D resistant rickets. Finally is renal rickets. Classical vitamin D deficiency rickets, hypophosphatemic rickets, vitamin D resistant rickets, and renal rickets. So some other deficiency manifestations are osteomalacia. So osteomalacia, the bones are softened due to increased demineralization of bone. Bones are softened due to increased demineralization of the bones. So patients are more susceptible to fractures. Okay, patients are more susceptible to fractures. Bones are softened due to increased demineralization of the bone. Then another type of rickets is there called rickets rosary. Details are not important, just remember type of rickets rosary. Then there is Harrison's sulcus. Harrison's sulcus, rickets rosary, osteomalacia, and the general form of rickets, the types of rickets. I've seen this deficiency manifestation. Next we are going to discuss is toxicity. Toxicity of vitamin D. Okay. Toxicity of vitamin D occurs when the level increases greater than 4,000 international units. So IU is international units. This causes calcinosis. Okay, this causes calcinosis in infants. The level goes beyond 2,000 international units. Okay, this calcinosis causes contraction of blood vessels. You know, calcium is an important vasoconstrictor, so this toxicity of vitamin D can raise the level of calcium beyond normal, causes contraction of blood vessels. There also occurs metastasis, calcification, metastatic calcification, it is deposition of calcium in blood vessels. This can also be one of the reasons for contraction of blood vessels. Calcinosis, contraction of blood vessels; metastasis, calcification, is deposition of calcium in the blood vessels. In infants, the level greater than 2,000 international units. In normal adults, toxicity is defined as the level greater than 4,000 international units. Thus, in the toxicity, now we are going to see some sources. The richest source we know is sunlight. Okay, sunshine vitamin, richest source is sunlight. Then richest source, dietary richest sources, remember halibut, liver oil, the only animal source is fish. Halibut is a species of fish. Okay, the only animal source of vitamin D is, remember, fish. Next we are going to see the all important RDA, required dietary allowance for children. Remember, it's 10 microgram per day, which roughly translates to 400 international units. Okay, in adults it is 5 million micrograms per day, roughly translates to 200 international units. Okay, in pregnancy it increases to 10 micrograms per day. Pregnancy and lactation, 10 micrograms per day, which is roughly 400 international units. Children, adults, and pregnancy, 10 microgram, 5 microgram, 10 microgram per day. 400 international unit, 200 and 400 international units. Microgram per day, international unit, important, remember. So with this we conclude our vitamin D discussion. We have seen the forms, we have seen the metabolism, where it acts in three places: intestine, kidney, and bones. How it acts with parathormone. Remember, vitamin D increases both calcium and phosphorus, but parathormone decreases the level of phosphorus. Then we have seen the toxicity and nutritional rickets, some deficiency manifestations. Lastly, we have seen the sources and the RDA required. Very important fat soluble vitamin require revision. So thanks for watching, guys. I will catch you in the next one. Good luck.